Okay. Hi, Gil.
Hi, how are you?
Hi, I'm fine, thank you. How is the weather there? As hot as in Belgium?
I'm not sure what your temperatures are like, but it's not too warm here. Probably Fahrenheit somewhere in the 70s. We had some smog issues from some fires up in Canada, where the
Yeah,
entire Northeast was covered for a couple of days, but we're back to clear.
right. Okay, that's better. So we're live already. So I want to welcome all the viewers already here, joining us in the chat. Already a lot of questions there. I also had a few other questions prepared from Facebook, from under the other YouTube channels. So this is the TRT and Hormone Optimization YouTube channel. And as a guest, we have back with us Gil. Welcome, Gil.
All right, thank you so much. I appreciate you bringing me on as always.
Thank you so much for taking your time to do this. So let's start with some prepared questions and then I'll take others from the chat box.
Okay.
We made a video the other day about TRT doses that don't always stay the same during life. So there was a question under that video and someone asked, generally, does the optimal TRT dose go up or down as you age? 40, 50, 60, 70, etc.
That is a pretty interesting question. I would say that it really varies by individual. There's no right or wrong answer. It really depends on the previous history, how long that individual's been on androgen therapy or androgen abuse in the past. A lot of guys come in somewhat desensitized to any form of testosterone based on many years of abuse and steroids. Those guys tend to need higher doses because they are desensitized. Their androgen receptors are not really giving them the symptom resolution that they desire. Some guys have comorbidities which require maintaining lower doses because they tend to spike in other lab values when they start increasing doses until you really get the rest of your life in order. And understand testosterone doesn't work for you, it allows you to work for yourself. So once you start to make changes to your sleep, managing stress and anxiety, changing the way you eat, changing the way you exercise, taking good, better care of your body and your health overall, things start to fall into place. And then you can start looking at dose adjustments. As your metabolism changes, metabolic syndromes start to dissipate. Things like diabetes, obesity, hypertension, dyslipidemia, etc., all start to dissipate with these changes. That's really when you could start dialing in. In some cases, you may need a little bit less. In a lot of cases, you may need a little bit more. But as you age and you begin to slow down your lifestyle in terms of physical activity and day-to-day body demands for things that are, active lifestyle related, like recovery and whatnot, oftentimes guys do quite fine on physiological lower doses. But there's a lot to do with kidney and liver function when it comes to metabolizing and excreting medications. And there's a lot to do with other underlying issues. So it's not a clear-cut answer as to whether it goes up or down. What is clear-cut is that your dose and oftentimes, if managed correctly, your frequency will need some level of adjustments. There is no such thing as cruise control unless all other variables stand still, and nothing stands still. At the very least, the earth keeps turning, we keep getting older, our bodies change, they start to break down and degrade. And there's no such thing as hitting a dose for the rest of your life.
Sure. Right. Are there any conditions where TRT is not for life, like when TRT is prescribed as a short-term treatment to address temporary causes of low testosterone levels, such as a medication side effect or an acute illness?
So if you have low testosterone and you are deficient for reasons of testicular hypofunction, where you're no longer producing proper levels of testosterone to meet your daily demands or your optimal lifestyle, that is not going to come back on its own. That is something that will relegate you to a lifelong treatment, or at the very least it should. The cases where I've seen where guys would go on therapy and then potentially come off are more so guys that were placed on for the wrong reasons, whether it was curiosity, whether it was performance-based, whether they were younger and they were quote unquote suboptimal or symptomatic, but they weren't clinically suboptimal. And they got on and they said, you know what, it's not doing what I anticipated. All these guys think they're going to get on there and they're going to look like Arnold Schwarzenegger, 4 weeks out. I could show you thousands of men on testosterone that don't look like they ever spent a single day in the gym. It comes down to your habits. All it does is increase the rate of protein synthesis. It allows you to rebuild and recover quicker. But if you're not in there doing the work and you're not eating to support that, it really isn't going to do a damn thing for you. So if you get on for the wrong reasons, I've seen guys come off, after a year or 2 or 3. But if you've been on TRT because you were prescribed for the right reasons, which is you are hypogonadal, you are deficient of the hormone, that is only going to get worse with age. Presumably, it is not going to self-repair, and you should be on testosterone indefinitely.
Okay, that's clear. Another one. The greatest advances in TRT will be the treatments that don't shut down your own production. Will that ever be possible, Gil?
We have treatments that don't shut down your own production, but again, your own production is moot because your own production is deficient. If you're looking to start TRT to replace a well-functioning endocrine system, you're missing the whole point of replacement therapy. It is not testosterone supplement therapy, it is testosterone replacement. And the goal is to replace what you have lost. And if you haven't lost it, why are you replacing it, is the question. And if you have lost it, what are we concerned about shutting down, right? When you have a 200,000-mile, 20-year-old vehicle with rust on it, do you just buy another vehicle and drive that one on the weekends, or do you trade it in for the new vehicle? You replace it. So why do you want to keep a flawed, failing system running or drizzling when you've already replaced it with something that is optimal?
Right. A question that we often see in our Facebook group with the same name. Gil, what's your message to men who often online ask for a cheap TRT clinic?
I don't know the word cheap. It's not in my lexicon. I don't ever use the word cheap in life. I don't want anything that's cheap. Cheap are things that are made out of plastic and break the day you buy them. Cheap reeks of low quality. Cheap is not a good word. Value is a better word. Everything has a value. We attach value to things based on the priority that we put in those things. And the higher the value, the higher the number. So you have to really assess what is the value of your health to you. And this isn't a double-edged sword question. I'm not here to knock someone who says I don't value my health tremendously, because that's okay. It's an individual choice. It doesn't make you a bad person. But have a serious conversation with yourself and decide what is the value of feeling my best and optimizing my lifestyle and making sure that my health does not continue to go downhill as I age. What is the value of that? And if you say the value is low, then you seek a treatment option that is of low cost, or where it has a number that matches that priority for you. If you say that value is moderate to high, then you seek a option that has a moderate to high number attached to it, so that you can presumably get, we're assuming here that you're getting value for number, that you're going to get the right value and the right approach to what you're seeking. If all you're doing is shopping your health to the lowest bidder based on numbers, then please expect the lowest outcome.
Yeah, sure. Someone asked, please get Gil back on about the prostate information. This old crap needs to be put to rest. He probably talks about TRT being bad for the prostate.
So Dr. Morgenthaler, who is a professor at Harvard Medical, he's also a prominent urologist out of Boston, as well as our very own Jordan Grant, who's a urologist in Paris, Texas, who's reiterated a lot of Morgenthaler's work. Morgenthaler has published a ton of Harvard papers on how this old nonsense about prostate health and testosterone being detrimental to it needs to stop. I believe he sits on the board of the American Urological Association, AUA. And I actually saw on PubMed, you can find this, he actually wrote an entire list of about 30 or 35 items that he wants the AUA to reconsider. It's like a mission statement of, he wants them to put out a mission statement debunking a lot of the nonsense. And he actually wrote this, I think it was published in 2019. You can find it on Google Scholar or on PubMed. Look up Abraham Morgenthaler, and you will find a lot of work that he's done on prostate. I know Jordan's got guys on active surveillance for prostate cancer, that he treats with TRT. So this whole androgen deprivation therapy, or ADT as they call it, that has been old, standards of care in urology to castrate guys, chemically castrate guys and crush their testosterone because they feel testosterone feeds prostate cancer, has been debunked. And this is evident by the fact that we don't see many guys in their peak testosterone years coming down with prostate cancer. We don't see guys during puberty, right? Testosterone, presumably on a natural level, is peaking at puberty. I know DHT peaks at puberty. This is the hormone that gives you the deeper voice, the male characteristics that defines, going from a boy to a man. This is all DHT related. DHT spikes during puberty. How come we're not seeing all these 16, 18-year-old boys coming down with prostate cancer during the peak of their DHT and testosterone cycles, right? Because we see this later in life, again, due to almost anything in our body. It's cellular degradation. It's the inability of your DNA to reproduce properly, and in some cases, overproduce cellular proliferation, which is what cancer is. This is not caused by testosterone. It just isn't.
Right. Someone asked, I would love to get a discussion on danazol for lowering SHBG, please.
Danazol?
Yeah.
So sadly we don't have Proviron in the United States, which I think is a phenomenal medication that would do wonders for guys with chronically elevated SHBG. You got to understand, SHBG being high is not something you need to get on and crush right out of the gate, because that is a missed opportunity to potentially diagnose a more serious underlying issue. Before you go and address an issue, the first thing you want to figure out is the etiology of this issue, right? In simple terms, why did it happen? What is the root cause? So when you're able to diagnose the root cause of something, it is then okay to go ahead and treat the root cause. Because if we crush the sign or the symptom, but we don't treat the reason, it's not only going to just come back, but that reason that's causing symptom A may cause symptoms B and C, and you may not be privy to that until it's too late. So don't just go and crush your SHBG because it's been at 85 for the last 2 years. Check out why you have it elevated. Check your liver functions. You may need an ultrasound. Check out other metabolic conditions. Check genetics, right? Does your dad and your brother have elevated SHG? Maybe that's just your number. Same thing goes for PSA. We've got patients with PSA of 5 or 6. They've been that way for 15 years. We're trending back to their primary care physician, from age 35, 40, 45. Now they're 65 years old. They've always had that number, and every DRE that they've had or prostate exam has been benign. So at the end of the day, you have to understand why a number is what it is. Danazol will lower SHBG, but you also have to look at other potential risks and side effects with every medication. Just like cabergoline, a dopamine agonist that lowers prolactin very effectively, very powerful medication, can have implications on the mitral valves of the heart. So guys like to just look at the indication of a medication and what it's used for. They don't like to look at the black box warnings and say, well, what is it going to do to me otherwise? There's much more efficient ways, especially for guys on TRT, to lower SHBG if in fact it is not due to an underlying cause that is missed, without using pharmacological agents to do the job. So there's dietary issues that could be addressed. There are herbal and over-the-counter supplements that could be utilized. And then there is frequency and dosing changes that could be done within their protocols in order to optimize their SHBG levels. Now, let me go back to the previous question, 2 questions ago, and reiterate, this is why I don't like the word cheap, because you're not going to get this type of stuff from a cheap provider. They don't have the time and knowledge to understand this stuff, because they have to do high volume to make up for their quote unquote cheap price. Yeah. So if you really need individual attention and support, seek out somebody who understands it, and then put a value on what it is that you're receiving for the service. SHBG is a very, very important key metric that we use, and I encourage all providers to use when managing guys on TRT. It's a fine balance between too high, too low, and how to keep it there. It's an ever-changing protein that you kind of have to, keep an eye on.
Someone asked, I have hyperthyroidism. Can I still do TRT? I think doing testosterone cycles caused my hyperthyroidism.
Hyperthyroidism could be caused by many things, including Graves' disease. Sometimes it's genetic. Believe it or not, steroid cycles tend to do quite the opposite. They tend to cause hypothyroidism. They tend to elevate your TSH, usually goes to 4.5, 5, and then sometimes it'll run up beyond that, and then it's gone. And then you have to go on thyroid replacement therapy. For the case of hyperthyroidism, there's a couple of different options. I know the first one they like to use is radioactive iodine, and then if that fails, they do a thyroidectomy, which is pretty brutal. You got to stay on a lot of medications for the rest of your life. Try to fix it first. Try to get it under control. Try to fix it. But yes, you absolutely, if you are deficient in testosterone, you certainly can and should be on properly managed and administered TRT. Oftentimes, thyroid and testosterone are interrelated. Remember, the signaling agents for both are the gonadotropins that come out of the interior pituitary. So both TSH, LH, FSH, thyroid and testicular stimulation both begin at the pituitary level. So if there is a pituitary issue, oftentimes we will find a thyroid, pathology coupled with hypogonadism. It's quite common.
Great, thank you. Under our Cialis video, someone recently wrote, I get horrendous back spasms from Cialis, but I don't from Viagra. Any way to mitigate this?
Yeah, it's funny because these are phosphodiesterase 5 inhibitors, and they all have similar mechanisms of action, but due to the half-life and the way by which the body metabolizes and releases the medication, they do have different side effect profiles. So tadalafil, which is a generic of Cialis, is known to cause some leg cramps and lower back cramps. If, in fact, you get those side effects, it's usually dose dependent. My first recommendation would be to lower your dose. We don't know anything about his dose and frequency, but guys that use it daily, I would say cut your dose in half or move it to every other day. It's a long half-life. That would be okay too. See if that subsides. If it does, stay there. If that doesn't subside, try discontinuing for 2 weeks and seeing if it subsides then, and then try to restart at a lower dose. When it comes to Viagra, it's a different side effect profile. That tends to give the sinus pressure headaches. It pulls the blood right in the center between the eyes, and it gives you like this uneasy headache. So that is essentially a faster acting medication, usually kicks in within about an hour, has about a 3 to 4 hour, peak effect, and then starts to subside. So both have the same mechanism of action, PDE5 inhibitors, both have slightly different side effect profiles. You got to play with the dosing. Some guys are more sensitive to it than others. I've seen patients that use Viagra or sildenafil, can't tolerate any dose. Seen the same with tadalafil or Cialis. And the same goes for Levitra or vardenafil, which is a generic form. But there are three popular, there are more, but there are three that I just mentioned that are very popular. You could play with the dosing and frequencies until you find something that works for you. If you're using it for erectile dysfunction, you should have a proper and full assessment, sexual dysfunction assessment, which is about 50% of what we do in our office every day. And there may be other options for you. If you're using it for other reasons, then, we'd have to know the specific reason and try to guide you a little bit better.
Okay. One last question before I go to the chat box. Can Clomid cause really bad stomach ache and diarrhea? I am trying to come off testosterone for a bit to get my wife pregnant, doing HCG and Clomid, but my stomach is killing me. Thanks.
Okay. Clomid's got a pretty terrible side effect profile, and if anyone has seen any of my stuff, they know I absolutely despise Clomid. I would never recommend it to any patient. With that said, I'm not aware of any GI issues caused by Clomid. There's psychological, neurological, and vision issues that are quite common with Clomid. This is the first I'm hearing of GI. What I can tell this gentleman is he should not be coming off testosterone in order to get his wife pregnant. He should get a proper fertility protocol. I have a short 3-minute clip on your channel, TRT and hormone optimization, that we did about 2 or 3 years ago. It was just a self video that I had recorded and you had asked me to upload it, and it spoke about fertility. It utilizes testosterone, it utilizes human chorionic gonadotropin, which is HCG, and it uses also a analog of follicle stimulating hormone, which generates spermatogenesis. So I do have a video on it, and we do have guys in our office that we prescribe and advise on that fertility protocol, and it works wonders. You don't want to come off TRT.
Right. I'll link to that video. Okay, then I'll get this out of the way. Okay, I'll come to the chat box. Hi, Bennett Joseph. He's in the chat box again. Good morning, Gil. He says, to what extent do you measure and treat DHEA and pregnenolone with your patients? Are they routinely checked or only when there is difficulty getting someone dialed in?
DHEA and pregnenolone tend to be slightly pricier lab tests for guys that have insurance-based labs. If they wish to run them, no problem. What I find is a lot of guys, usually when they begin TRT, they're okay initially. After a while, 6 months, a year, usually the pro-hormones upstream from testosterone, like DHEA and pregnenolone, they do tend to come down a little bit. When do we treat them is when someone becomes symptomatic. If someone complains that their sleep has suffered, we will often look at pregnenolone, which converts to progesterone. It's got a calming, soothing effect that helps you fall asleep at night. You will dose them until they get sufficient sleep without feeling groggy in the morning. So we use more of a feedback approach to dosing rather than a lab value per se. When you look into DHEA, some guys will develop desensitivity during sex, and they will have an inability to achieve orgasm. It's called anorgasmia, or they will have a delayed orgasm effect, which is the opposite of premature. And that in itself causes frustration, problems, lowers libido, because it adds anxiety to the process. In that case, usually DHEA, if in fact deficient, will help resolve that issue. So 25 milligrams dosed in the morning. With pregnenolone, we usually start at 10 milligrams dosed before bed. But it is patient specific. Sometimes it's based off labs, but more often than not, it is based off of symptoms. Mm-hmm. And I know Dave Lee loves to research those pro-hormones extensively, and he would be a better option than myself to discuss them.
Mm-hmm. I'll link to the lectures by Dave Lee as well. While on TRT with 0.5 milliliters every 3 days, do you advise also using NAD?
Okay, so 0.5 milliliters every 3 days, it comes out to about 220 milligrams per week if in fact you're taking 200 milligrams per milliliter concentration. I find that to be a fairly high, and again, I don't know the individual, maybe what they need. I find it to be a fairly high dose. NAD or NAD is something that is completely unrelated to testosterone therapy. It is something that has a lot of more recent research on it. It is still relatively a newer product in the medical field when it comes to performance and optimization. For those that don't know what it is, you can Google it, NAD, N-A-D. It is an infusion often given via slow IV drip. You will need to infuse it very slowly usually you start about 100 milligrams, infuse it over 90 to 120 minutes, sometimes a little slower than that, depending on the person's reaction. I was silly enough to have a colleague push it on me with an IV push, and it was not fun. I mean, this thing will make you feel it immediately. It feels tight in the chest. You feel pins and needles in your limbs. You feel very awkward, very warm. I did not enjoy the feeling, but I wanted to experience what it was like. So my understanding is when you drip it slowly, guys feel that on a very, very small level. And then if they don't like the feeling, you just slow the drip. What it's supposed to do, it's supposed to help the mitochondria produce ATP, which is cellular energy, on a more efficient level. It's supposed to cleanse the cells. It's supposed to increase energy production. I will say for the next 48 hours post-therapy, I did feel pretty darn good. I know guys will infuse it once or twice a week. It is pricey. It is extremely pricey. I think a normal dose in an IV bag will run you anywhere from $600 to $800 for an infusion. So imagine doing that 4 times a month. It is a luxury. It is a pricey product. I may do it again. I mean, I may order it for the office and try running, a month, once a week, and see if I do feel an improvement overall in my energy and my lifestyle. I may give it a shot as an experiment to see. Only tried it once. Interesting product for sure. More research to be done, but I would be cautious to say it's related to TRT in any way, shape, or form. Whether you're on T or off T, really, this is 2 independent topics.
Yeah, sure. A question we get often. How long should you wait to check your blood testosterone levels after changing your dosing protocol?
I like to say 8 weeks as a minimum for any changes to testosterone cypionate. And by changes, I mean whether it's dose, frequency, ester, anything. Any change, any variable change to the equation with cypionate, I like to go 8 weeks. The reason for that is the half-life of a medication multiplied by 5 gives you the time frame required to achieve what is known as a steady state. So with cypionate being approximately 7 days, and it's approximate because the pharmacokinetics tell us that it's 7 days, but the pharmacodynamics, which is how the body reacts on the medication, varies from patient to patient. So it could be 6 to 8 days, but let's call it 7 as an average. 7 days times 5 is 35. So you're looking at 35 days to achieve steady state. And right there, you're looking at about 5 weeks. Then you're going to go an additional 3 weeks or so, or a month, to make sure that you're living in that steady state and you can kind of feel and see the changes. And that's when you want to pull the labs. Now you have your subjective feedback of, hey, I've been living in this steady state for a month. I know how it feels. I can report to you. And then you have the objective data, which is, hey, I've been in a steady state. Here's what my blood tells me. So I would say 8 weeks should be a sweet spot. Definitely no less. If you want to go longer, again, as long as you don't make any additional changes, you can go longer than that as well.
Mm-hmm. Great. A question you won't like. How much is 4 pumps per day of androgel 1.62% equal to, in comparison, versus the standard average recommendation of TRT injection, which I believe is 100 to 200 milligrams per week?
There is no conversion from topicals to injections. When you go to injections coming off a topical, you're essentially starting from scratch. Again, going back to pharmacokinetics, there are 4 things that are the primary mechanisms of pharmacokinetics, or PK as we call it. It is the administration, it is the absorption, it is the metabolizing of the medication, and then the excretion of the medication. And that changes everything when you change the form of administration, which is the first step of PK. So when I change from a topical over to an injectable, I am completely changing the rate of absorption. And that is to be seen with each individual patient. Pharmacodynamics, as I said, is the opposite. It is what the body does to the drug. Pharmacokinetics is what the drug does to the body. So what we need to do now is we need to assess the patient from scratch. We need to figure out what's that drug going to do to his body, and then what's his body going to do with the drug. How quickly is it going to excrete the drug? How quickly is it going to metabolize the drug? All right, so all of these things need to be assessed from scratch. There is no table or chart that tells you if you're using X amount of topical, you're automatically on X amount of injectable. The only data we can kind of slide over is, well, what were your lab values on your topicals and how did you feel at those lab values? And even that I would take with a grain of salt, but at least it's a metric that could be considered. So you're not exactly starting from scratch, you're starting with a little bit of experience. With that said, I have to put this in there. Androgel is absolute junk. 1.62% water-based or alcohol-based topical, absolute junk. I know, Stephen, you're on creams yourself. I know a lot of guys are fans of creams. Personally, we know I'm not. I've also made a video explaining why I'm not a fan of creams. It lacks the control, and there's a lot of other disadvantages that I see. If you make it work for you, that's great, and I know you do, and I know you've been on it for years. Kudos for that. Those are much better. The compounded creams are much better. They are not to be confused with androgel. That androgel is absolute junk. I would not recommend using it at all. So congrats to the question asker for moving from androgel to, I assume, cypionate. But the short answer is there is no specific dose conversion. You're going to have to start from scratch, and hopefully your provider understands how to manage that correctly. Although I hope it's a different provider, because if he started you on androgel, that's a red flag right out of the gate.
Right. An interesting question. How long does it take to see body composition improvements on TRT? I am eating clean and working out 5 days a week.
Unrelated. It's got nothing to do with TRT. It's got to do with your training and your diet. Here's the thing. If you want to change the way your body looks, and it is not happening according to your expectations, There's one of two things that are at fault. Number one, you have set unrealistic expectations. Reassess your expectations. Number two, you're not eating and training to your goals. You may think you are, but the evidence says otherwise, because if you are, you'd have the result. So if you're not getting the results you want, you are not eating and or training correctly. Seek a professional who understands how to put that plan together for you. Or as I said earlier, you may have unrealistic expectations based on time frame. Nothing to do with testosterone.
But surely TRT, if you lack testosterone, will help you in motivation and getting to your goals.
It should, not always. I've seen guys with deficient testosterone levels that are absolute beasts. I've seen guys with testosterone in the teens that can't get out of bed, right? So it should, but this is not a clear-cut, black and white topic either.
Right. Scrolling to the questions. Some people are writing down their numbers, but not even asking questions. So that's difficult. Okay. Hi, I have just started TRT, 150 milligrams per week. My TRT comes in pre-filled syringes, but I have to backfill them into smaller syringes for 0.3 milliliter injections. How can I limit wastage?
Request a prescription for a 10 ml vial of testosterone, and then get yourself some insulin syringes. Go on my website, elevatewellnessgroup.com, click on Knowledge Base, and watch video number 68. And it's a 2-minute video where we demonstrate a proper injection, drawing protocol, injecting protocol, etc. 2 minutes. Video 68 on elevatewellnessgroup.com. Call your provider and say, please prescribe me a 10 ml vial. Do not take preloaded syringes.
Yeah, of course, this gentleman might be in a country where it isn't available, like in Belgium. We only have
It's
injection
possible.
pills.
Perhaps, but it would be helpful if they stated that, because I've seen a lot of debacles here in the U.S. and they do have options.
Yeah.
So without knowing where he's located and what the options are, it's a little hard to answer. If you have to backfill, then you're going to deal with waste. I mean, you're not going to suck that last tip out of a needle.
Right. I recently made a video on my other channel, The Lifting Dermatologist, about people always stating, no, I can't find time to work out, so I'm fat, and they use not having time to exercise as an excuse to remain fat, really.
Do you remember what I said initially? When you asked about cheap, I said we prioritize things differently. To them, their health and their body is not a priority, and that's okay. As long as they admit it. Don't tell me I can't find the time. We all have 24 hours in a day. I have 24, you have 24. Elon Musk has 24 hours in a day. It's the one thing he cannot purchase more of. He can't write a check for $1 billion and have a 25th hour. We all have 24. What you do with that time is voted on by your priorities. Where and how you spend your time tells me what's important to you. So we all can find the time to do the things that are important to us. Just stand up and say, training is not important to me, or I don't enjoy it. How I look and how I feel is not important to me. It's okay. It's okay to say that. Be honest with yourself. We're not here to judge you. But if you're not honest with yourself and you keep telling yourself, I don't have the time, if that makes you feel better, have at it. But you have the same time that everyone else does. You choose to use it differently. That's the difference. Yeah. I don't have the time to watch TV. Therefore, I don't have a TV in my home. I don't have the time to watch TV because those 24 hours are better used elsewhere. If I have an hour of downtime, I'd rather research, I'd rather study, I'd rather read, I'd rather play with my kids, I'd rather do something that I enjoy for leisure, rather than sit in front of a box and watching a reality show. But that's my decision, that's a priority. So if you have a television, if you're watching a football game, or if you're watching a reality show, or if you're watching the news or the weather or politics, that hour could be used in the gym. You just choose not to. You have the hour, you spend it different. Yeah. Right? If I have $10, I could buy a slice of pizza, or I can invest it in the stock market. But if I buy a slice of pizza and say I don't have money to invest, I had the money to invest, I chose to use it elsewhere. No different.
Yeah, exactly. Oh, the gentleman says about the pre-filled syringes. I have already requested the 10 milliliter vial for the future, but I just wanted advice from for the interim. Thank
Yeah,
you.
so you're going to have waste. Who cares? Testosterone is so inexpensive. It costs next to nothing. So you're going to waste, you know, a quarter of a milliliter out of 10 ml. Big deal. You're getting a refill anyway. You know, everybody's so worried about cost of testosterone and waste. Who cares? I usually throw my vials out when there's half a cc left because I don't want to start fiddling with drawing out the last. I mean, it costs nothing. It costs nothing for a vial of testosterone, 20, 30, 40 bucks, right? For 3-4 months worth of medication.
Another question I recently had was about water retention on TRT. A lot of people still mention water retention in the beginning of their TRT journey. Is there something they can do or just wait it out?
I'm going to touch on it briefly because we have a video specifically on this that you and I did about 3 years ago, and it's on the channel as well. When you take an anabolic steroid, which testosterone is, androgenic anabolic steroids will lead to an increase in other mineralocorticoid steroids. For those that know what Cushing's disease is, it is a massive, rapid increase of all steroid hormones. And your adrenal glands secrete hormones as well. And one of them is aldosterone. Aldosterone, secreted by the adrenals that sit right on top of the kidneys, enters the kidney and tells it to reabsorb sodium. And sodium reabsorption carries water with it. When you start TRT or you change dosing or you change protocols, aldosterone spikes will occur transiently. This means that they will occur and then over time subside when you find homeostasis. In that time frame, expect water retention. If you're eating a good diet and you're exercising correctly and sleeping correctly, that water retention will be intracellular. This means it will inflate your muscle tissues and possibly intravascular, which means that you may notice a mild increase in blood pressure due to something called hypervolemia, or an increase in blood total volume. It is not necessarily bad because it will also lower hematocrit by hydration ratio. At the same time, if the blood pressure gets out of control, it can be bad because it still stresses your kidneys and your heart. Elevated blood pressure is the #1 cause of renal failure that leads to dialysis over time, but that's when it is chronic. It is also the #1 cause of something called LVH, or left ventricular hypertrophy, which is the thickening of the wall of the left ventricle of the heart, which is the main pumping chamber into systemic circulation. So don't ignore elevations in blood pressure, although if they are transient and not very sufficient, they will subside with a proper lifestyle. Hydrochlorothiazide is a common prescription to combat hypervolemia. It dispels water out of the blood vessels. If you're leading a lifestyle that is less than optimal with regards to nutrition, that aldosterone spike will absorb more sodium. If you're eating a lot of bread, which is the #1 source of sodium in the American diet, bagels, things of the sort, if you're eating a lot of canned or bagged foods, they're all preserved with sodium, you're going to blow up. You're going to have interstitial edema or third space edema, which is the fluid spilling out of your blood vessels into the space between your skin and your other tissues. So you're going to essentially have bloat. You can blanch it when you touch your wrists and your ankles at some points. You'll notice it kind of almost like a doughy sensation, especially in the lower limbs. Diabetics have this due to poor circulation. You'll notice a lot of the edema in the ankles and feet and the swelling. They'll wear compression socks. So that is a severe situation that requires attention. If it is transient, like I said before, clean up your diet, increase your potassium intake. Potassium is exchanged in the cell with sodium. So if you eat sweet potatoes, if you eat avocados, those are rich sources of natural potassium. Bananas a little bit, not so much, but sweet potatoes and avocados, phenomenal potassium sources. You may supplement with potassium citrate, which is another supplement. If you are a patient on heart medication or you're under the care of a cardiologist, please do not supplement exogenous potassium because it can cause arrhythmias and other problems. So speak to your cardiologist first. But overall, the water retention will subside once the aldosterone settles down. And oftentimes I see guys overdosing with testosterone as well, which is another issue.
Right. The interesting question was, is testosterone for someone who's hypogonadal, is it good for longevity? Will it make you live longer, or will turning up the metabolism just deteriorate your lifespan?
So testosterone, fixing any deficiency, anecdotally will make you live longer. Because if your body needs something and you don't have it, you're dying at a faster rate. You are breaking down. That is what a deficiency is the inability to keep up with demand, right? Therefore, replacing a deficiency in theory should make you live longer. It is multifactorial. You're going to have to make lifestyle changes. The good news is testosterone will give you the motivation, the energy, the drive, the desire, and there's nothing more motivating than seeing changes. So if you get that initial motivation to get up and do things, and you start to see body changes, you become even more motivated, and all of a sudden you wake up one day and 6 months in, you say, my whole life is different than it was 6 months ago for the better. So absolutely, I've noticed guys that begin TRT are driven to exercise more. They're driven to get out and do more physical activity. They are driven to change their diet and do better. They're driven to take care of their sleep. They make more money because they are driven and motivated once again. They have that natural male aggression to get out there and succeed. And as a result, all of those things combined should give you longevity. With that said, you can step outside, you can get hit by a bus tomorrow, and then no amount of hormone is going to be relevant. So we could only guess on longevity. But I bet if you conducted a study of guys who are deficient, left them deficient for 30 or 40 years, then took a sample pool of similar guys who are deficient and put them on properly managed and administered TRT, let them go out and do their life as they please based on that, without any additional, guided changes, I guarantee you that the guys on properly administered TRT would live a longer and, more importantly, a fuller and more rewarding life. It's not all about the years in the life. It's a lot of it is about the life and the years, right?
A related question there. Dave Lee and Dr. Rudy Eberwein, they all already talked a lot about mental health and testosterone. What's your take on mental health for guys on TRT? Does it really work against depression?
Yeah, so testosterone has been known to have neuroprotective and neurotransmitter effects. Oftentimes, guys that have low T symptoms will report to a clinic and then be prescribed an antidepressant, anti-anxiety, benzodiazepine, SSRI. Terrible approach, absolutely terrible. We noticed that a lot of guys that begin TRT report feeling better. Their mood improves. Again, the lifestyle changes they make further exacerbate their mood improvement. They usually come off the antidepressants. And usually, we find that guys who have some level of anxiety directly correlated to low T tend to subside. So I've seen guys who intermittently use Xanax as needed, stop using the Xanax. I've seen guys using Adderall for ADHD report less Adderall use. I've seen guys on Wellbutrin and benzos and other Zoloft all of a sudden say, hey, I'd like to wean off. I'm going to reach out to my doc and see if he can kind of wean me off. I think I'm doing well. So that's been reported anecdotally as a result of proper TRT. The one thing I will caution, there are guys who suffer chronic anxiety. It is underlying for reasons outside of hormone deficiency. It could be lifestyle, it could be genetic. It could be PTSD, a lot of trauma, it could be from childhood, it could be from other things. Oftentimes those guys will start TRT and they'll notice their anxiety increase initially. And they'll blame the testosterone for it, but here's the problem. The problem is that they thought testosterone was going to resolve every problem in their life. It's just not how it works. So when they start testosterone and the anxiety is still there, they almost lose a sense of hope. And if you think about anxiety and what it means, anxiety is nothing more than worrying about your future. Depression is living in the past, and anxiety is living in the future. And the biggest part of anxiety is hope, having the hope to a bright future, having the hope to a pleasant and enjoyable future. And when that idea becomes grim and you start to lose that hope, that's where anxiety kicks up. So when guys see TRT and they have anxiety, those guys tend to research for 6 to 12 months before they get on treatment because they're so anxious about everything. They got to know every stone's been turned. When they finally make the decision and they read all these reports about guys feeling great and they get on TRT and their anxiety is not alleviated because it's completely unrelated, their mind is blown. And now they've completely lost hope because this was their last saving grace. And that's when the anxiety really comes off the deep end. So I would caution guys with severe anxiety that's due to underlying issues unrelated to hormones. Don't think TRT is going to fix it. It may make it worse. It doesn't make it worse on a physiological level, but on a psychological level, you're setting yourself up for false expectations, and you're going to blame your treatment for the increased anxiety while it's all up here.
Yeah.
So be cautious. I've seen it hundreds of times. It's sad to see, but they really fall apart.
Great advice. Our friend with the pre-filled syringes writes, it's $40 to $50 a vial for test. It's very cheap. Here in Australia, it's much more expensive. So I try my best to limit the wastage. Does your clinic ship internationally?
No. First of all, the clinic, testosterone is a Schedule III controlled drug in the US. Clinics do not carry testosterone. They do not ship testosterone. At least they shouldn't, not legally. Pharmacies do that. All we do is send in a prescription. The pharmacy handles the medication. We can't touch it. It goes right to the patient. But this question is asked all the time. People should know that you cannot write a prescription outside of your jurisdiction. And when you have licenses in one country, you are licensed in that country. I know the EU is different, but it's more of a union. The United States is similar. If we have a federal license, yes, we have to have state licenses and whatnot, but we treat in the US. We cannot medically treat a patient outside of the borders of the United States. Okay? What I can do is I could do informational consultations with people worldwide, just two guys talking. It is a non-official, non-medical consultation. It's just, you get 30 minutes to get me on a Zoom call and ask and talk about whatever you'd like. And I think you have the link for that in your videos. But other than that, when it comes to medication and official medical treatment, you have to be a resident of the United States in order to work with my clinics. We do nationwide telemedicine, but you do have to be in the United States for that.
Yeah, here we can prescribe for international patients, but it's within the European Union.
Right.
Like, for example, Belgium is a very small country. When I take my car here, I can drive to the north to Holland in 30 minutes. I can drive to the south to France in 30 minutes.
Right. You could prescribe to a patient in Greece, but you can't prescribe to a patient in Canada.
Exactly. So
same thing here.
Yeah, I have Belgian patients. Yeah.
My New Jersey office can prescribe a patient in New York, but not a patient in Canada.
Yeah. So it's the same for United Europe.
Right.
So few more questions. Not my proudest moment, but I begged and my endo agreed to prescribe me HCG. What is the range of optimal dosage to be on it? PS, my low T is because of microadenoma on my pituitary. Total testosterone was 128. Okay.
Benign microadenomas in the pituitary are quite common for a lot of guys as they age. You just monitor it with an MRI every 2 years or so. HCG, it depends on his reason for taking it. So what I find is for guys on fertility, we discussed earlier a fertility protocol, which will require FSH and higher doses. For guys who take it simply to prevent testicular atrophy, which is notable for about 25% of men who start testosterone treatment, HCG does a great job at reversing and preventing this, assuming that their hypogonadism is pituitary based or secondary hypogonadism, as we call it. In this male, because he does have a pituitary adenoma, I'm going to assume that this was a luteinizing hormone insufficiency or pituitary hypofunction that led to his low T, in which case his testicles presumably have properly functioning Leydig cells, which would respond to an LH analog like HCG. I would venture to say that 400 IUs of HCG administered biweekly or twice per week should be sufficient to prevent and or reverse testicular atrophy. I would start at that dose, assess within 4 weeks, and titrate as needed.
Thank you. Is Tadalafil good for erectile dysfunction on TRT? We have a whole video on that. I don't know if you want anything to add to that.
In short, yes, maybe, depending on the etiology or the root cause of your erectile dysfunction.
Yeah, sure. Bene Joseph, my GP has me on 1 a week. Is that good or a bad level? Just kidding. Yeah. Yeah, long question. I'm currently on 100 milligrams a week testosterone. Recent blood work completed on the 7th day before injection. Total testosterone 636, free testosterone 126, SHBG 32, E2 35. Would you recommend changing to 50 milligrams twice a week?
At least. At the very least, change it to twice a week. You may require a slightly higher dose, depends on your height, weight, and symptoms, which are very important. We have no subjective data on this gentleman. His free T is less than 13 nanograms per deciliter, which is extremely suboptimal. His total T is in the 600s with an SHBG in the 30s. Again, this is on a trough because he's only injecting once a week. I would say go to 50 milligrams twice a week for 8 weeks, retest, have a proper discussion about your subjective symptoms, and at that point, you could titrate up to 60 milligrams twice a week if needed, unless you find symptom resolution where you're at the 50 biweekly.
Mm-hmm. He also adds he's doing shallow quad intramuscularly injections. Probably you want to give him some more advice there.
Get rid of the quads, go to elevatewellnessgroup.com, click on knowledge base, and watch video number 68, where I explain how to do a proper injection.
A question we recently asked in one of the videos, why are European doctors, even endocrinologists, so incredibly uneducated about sex hormones?
The same reason that American doctors, Canadian doctors, Australian doctors are uneducated about sex hormones. You cannot make a living specializing in this field and take insurance at the same time. So if you are what we call a participating provider, which means that you are credentialed with the insurance companies to accept insurance, the only way you can make a living is by bringing patients in high volumes and billing for office visits and procedures. You don't get paid when someone takes an injection at home. You don't get paid when you send a prescription to the pharmacy. You get paid when someone's butt is in a seat in your office and you have 7 minutes to round that room and then go on to the next room, so you could do this 60 times per day, collecting $150 per person from their insurance. And then you wait 3 months to get paid. That is a flawed model to subspecialties. It may work for primary care, urgent care, sore throats, antibiotics. It does not work for hormones. So when you go to a specialist, they get, like endocrinologists make money managing diabetics. Okay, urologists make money taking out prostate cancer and installing implants. They're surgeons. They make money when they have a knife in their hand. They don't make money talking to you about your luteinizing hormone and HCG. They're not going to dedicate their education and run their business model around something that doesn't earn a living. That's not the way that system is designed. We get paid by the patient to do a proper 30, 40, 60-minute consultation, to read their labs and understand their labs. We stay on top of this. We study this 12, 16 hours a day. We attend conferences with colleagues. We share information. We read relevant studies. We do Q&As like this to put out information for free to you guys and other providers, because this is what we're paid to do. I am paid every single month by a lot of people to do this. Your urologist is not paid to do this. Your endocrinologist is not paid to do this. They're not going to go out there and spend 6 months of their year in the book and in the studies for a $150 office visit. By definition, it's impossible. So it's not that they're uneducated because they lack the brain capacity or the intelligence to comprehend. Their level of understanding in a field where they don't get paid is similar to my level of understanding in women's shoes. I know they come in different colors and sizes, and that's where my knowledge ends. You know, if you wanted to pay me a lot of money to go and study women's shoes, give me a year and I'll be an expert. But nobody's paying me for that, and no one is paying them for this.
Right, exactly. Yeah, I saw something. We are nearing the end. We're almost 1 hour in. Is there any evidence on switching esters? We have a shortage on cypionate. I was switched to enantate.
I don't know what country he's in. There's certainly no shortage of cypionate here. We fill hundreds of vials a month with the pharmacy, but if his country has a shortage, then enanthate is the closest you will get to cypionate. In terms of half-life and overall molecular structure, enanthate is the sister to cypionate. So give it a try until you get back to the medication that becomes available to you.
TRT is causing me not to be able to sleep more than a few hours at night. I get tired during the day and have to take a nap. Is it typical to have sleep problems on TRT?
TRT is a general term. I have no idea what medication he's using, how often, what dose, and what ancillaries.
Right. Give us a bit more information there. Okay, I think I only have secondary hypogonadism. How do you test for primary hypogonadism? Is it possible with blood tests to check if the Leydig cells are an issue or not?
Yeah, stimulate the Leydig cells. Use a luteinizing hormone analog, stimulate the Leydig cells, and retest your levels. Mm-hmm. How does a plumber find a plug or an occlusion in a pipe? You start at one end, you find the junction, you clog it, you run the water, and if it goes through, you know that section is cleared, and then you move to the next section. Mm-hmm. We're going to bypass your pituitary and check your testicles. If they work, great. If they don't work, we found the problem. Mm-hmm.
Oh, the guy with the sleeping problems, he says androgel.
I rest my case.
Yeah,
you're not on TRT, my friend. You're on ADT. You're on androgen deprivation therapy. You're chemically castrated. You're not on TRT. You're not replacing anything. You have shut down your endocrine system and failed to replace it sufficiently. Mm-hmm. And therein lies the reason why I can't answer general questions without specifics. And that is only one key factor that he has given me, and it's already worse than I had thought. Mm-hmm.
Okay. Maybe last question. Taking TRT 200 milligrams a week, free test 270, total test 985, E2 93. And now the question, would you consider an AI or lower TRT dose? Symptoms, daily migraines and bloating.
Okay. I would never consider an AI. I would never test estrogen in a man. It's not relevant. If you're taking 200 milligrams once per week, already flawed, incorrect frequency, likely too high of a dose. Drop the dose, split it in two for starters. I don't know what his SHBG is. If I knew his SHBG, I can give him a more precise frequency. Out of the gate, doing this all wrong. Already doing this all wrong. Mm. So I do expect some side effects in this gentleman because he's doing it wrong.
Right. Okay, to end this, Gil, I've already seen several questions asked in the chat box. How may I contact Gil for a consultation? So share that with us.
So there is a link in the description that Stephen puts in. If you would like to just speak with me for 30 minutes and nothing more, it's an informal conversation that has no medical bearing to it whatsoever. We can talk about anything you'd like, medical or otherwise, but it's not an official medical consultation. It's available worldwide via nextleveldietetics.com. The link is in the description. If you'd like medical help within the United States via telemedicine, which is available to US residents in most states, I think 46 states, you can go to elevatewellnessgroup.com, click the telemed link at the top, just give us your name, phone number, and email. One of my patient counselors will give you a call to answer all of your questions. And if you choose to proceed, we will send you a requisition for labs. We'll get some blood work done. We'll get on the phone with you and we'll explain everything that you need to know. Do a nice 30, 40-minute consultation, get through all your questions for you. Again, it's elevatewellnessgroup.com. Click on the telemed link and put in your name, phone number, and email. We will call you within 24 to 48 business hours.
Okay. I know you're not watching the chat box, Gil, but I want to mention a lot of guys thanking you. Awesome video. Thank you. You guys are a wealth of knowledge and so on. So thanks again, Gil.
Thank you. It's a pleasure, and I appreciate the kind words. This is why we do this. We just want to put the information out there, dispel the myths. It's an uphill battle over the last decade. We've put out a lot of stuff. I've put out a lot of stuff on various channels. I've done by far the most on your channel, and I've noticed that as much as these questions linger about the AIs and the other nonsense, they are starting to come around. They're starting to dissipate, and the tides are turning. Maybe another decade or two, but we're making headway, and that's why I do this.
Sure thing. Thanks again. Enjoy the rest of your weekend.